Um, oh yeah, so we are recording this, and Derek is very generously allowing us to share the recording and the slides afterwards with all the embedded links. So we'll be able to share that with everybody. So that's brilliant. For those of you who don't know, I'm sure you all do, Derek was a professor of rehabilitation at the Oxford Centre for Enablement and a visiting professor at Brookes and Maastricht universities. He has written extensively in the area such as stroke rehab, what constitutes rehabilitation, a minimally conscious state. He has collaborated with physiotherapists in research. He is officer deputy in the executive committee for the British Society of Physical and Rehabilitation Medicine and is the editor of Clinical Rehabilitation. He runs a webpage regarding all matters rehabilitation called Rehabilitation Matters, which is for clinicians, academics, as well as patients and the public. Derek's a keen supporter of allied health professionals and psychologists and recognises the value of an MDT approach for the benefit of patients. So thank you, Derek, for joining us.
Thank you very much. Thanks. I'm also a member of ACPIN, as it happens.
Oh, very good.
An honorary member, that is. Okay, well, thank you very much for inviting me. You've already said the slides are available and you can use them and do what you want with them, and I'm very happy with that. I should preface what I'm going to say by saying that I'm not, in my view, a pain expert as you are. So what I say about pain, you can correct if you want to as we go along. I'm very happy to receive questions in person or online, which Rachel will deal with as we go along. So if you disagree, you want to ask a question, I say something funny, just put your hand up and we'll deal with it. So this was the title I think I was given, or maybe I gave it to myself. And I was reflecting, I'm not actually sure whether pain care is a sort of term of art or just pain care. And I've taken it to mean specializing in looking after people with pain. So the point at which has been working very well up till now is now given up. So the question is, in a sense, the top of these three figures shows pain care one side, rehabilitation the other side, and the wall between the two. And is that how we are? And is that the connection between rehabilitation and pain care at present? If I reflect on some parts of the country that I'm aware of, certainly rehabilitation would see itself somewhere over here with a big red wall between it and anything else, including pain care. Or are we like the middle row, which is we're friends, we're next to each other, but still pretty separate? Or are we actually down the bottom? We're all part of the same service. Now, we're all part of the NHS, fairly obviously, but are we part of the same philosophical and practical service? And that's the question I'm really thinking about. Yes, it's going, right? So what I'm going to do is to talk about some initial challenges about pain and the nature of pain, and that's something you can correct me on and we can talk about. I think probably most of you know what rehabilitation is, but nevertheless, because it might be different from what I think it is, I'm just going to set that out. And then I'm going to consider the relationship between pain care or services that deal with people with pain and rehabilitation, and to see in what way they're the same and in what way they're different. And the messages that I'd like to get across are the biopsychosocial model, which I have to assume that you are aware of, predicts that chronic pain will exist. That may seem rather banal, but it is quite an important validating phenomenon that makes the biopsychosocial model a valid model. And it will gives you a sort of way of looking at how pain is or how rehabilitation is. I need to look at my slides just to check that I can do what I'm saying. Yeah, so it also predicts that most things in health or most illnesses in health won't have a single unique cause. There's lots of things going on. It allows a fuller understanding of pain and its context, and you'll know that, I hope. And it suggests factors that you can try and do something about. And it's it allows you to think about how you're going to control pain and deal with it. And I would argue that pain and rehabilitation, pain control and rehabilitation use the same approach. The difference is that in your services, you're dealing with pain as your area of specific expertise, same as in a rehabilitation service, it's complex disability, but in some rehabilitation services, it might be prosthetics or it might be wheelchairs. They're all part of a whole. And so we're on a spectrum or a rainbow, so different things that we specialize in. So that's what my messages are. And that's just a break. I don't expect any questions or imagine so far, because I haven't said anything very much. So my first question to you is this the goal of pain management? So when I was devising this talk a few days ago, I just put in something like goal of a pain service into Google, and this is what I got out, number 1. You can read that, but essentially it's saying the goal of a pain service is to find the cause of the pain and cure it, which is, in my view, a very medical, if not surgical, approach. It's a very biomedical, professionally driven approach. It assumes that all chronic pain has some treatable single cause that we can find, because that's what they say they do. And this is for chronic pain, I should say, it says that. And it also leads patients to believe that's the case. So patients who go to the London Pain Clinic, which I assume is around here somewhere, I don't know it, will all be going with the expectation that a cure will be found and they will be cured. And I put at the bottom a question for you, which I assume you probably don't do, but do you set your patient goals at reducing the intensity of pain? You don't have to answer that, but that's the question. The alternative, which came up a bit later on in Google, was this. Primary goal of chronic pain management is to reduce distress, disability, and suffering. And it makes the statement a bit further on in the same sentence that pain intensity is not the best outcome for the success of a chronic pain service. The references there, you can click on the links and you'll get there. And this is, to me, much more a rehabilitation approach based on a sort of holistic biopsychosocial model of health and illness. And that I imagine that we can debate it either now or later on, that your goals for most patients is around doing things and living life and being social. So those are two sort of extreme ends of what pain services are going to do. It's my experience, unfortunately, that many pain services in the NHS actually go for the first and talk as if, act as if there is a cure for a single cause. If there's any comments coming up, you'll interrupt me.
I will.
Okay. So what's the goal of rehabilitation? So I'm going to do 2 goals, same sort of thing. I think that a lot of managers, commissioners, and some people running rehabilitation services feel the aim is to get a patient out of hospital as quickly as possible. And that's all that a lot of OTs and physios actually are allowed to spend their time doing. And then perhaps a bit more ambitiously to get people independent in self-care, but largely because that makes it easy to get out of hospital and there's less problems setting up care packages. And this sort of goal, which unfortunately I think applies to quite a lot of rehabilitation services, is again biomedical and service centered. You know, you come to this service because we do this therapy, that therapy, or whatever it might be. And if that's what we think you need, or then we'll offer it. It's like they say about a dozen and a hammer. To a man with a hammer, everything is a nail. And that's the view of quite a lot of rehab services. Or is it a broader goal? This is one that I set, but I mean, this is not unique to me. It's just phrasing what other people phrase as well, which is around quality of life, which is the patient's decision, social integration, and of course, you need to be as independent as possible to get there. But your goals are around social matters, and the reference is there. And this is much more person-centered, I believe, holistic, and again, it's based on the biopsychosocial model of illness. So that's the sort of two ends of what the services are trying to do and the two services. Okay, so I'm just going to go through three things briefly, which are my assumptions, which you can question as we go along, but I'll just state them and then I'll go back to them. First is that chronic pain has no single cause. I think that, I hope nobody disagrees with that, but that's certainly my very strong belief. And that is true about a patient, for this patient. It is also true about the totality of people in a chronic pain service. Second, and this may be more debatable, but I will state it because I think it's true, that actually you can't subdivide chronic pain. If you've got chronic pain, you've got chronic pain. And we'll come back to that in a moment. And of course, there's variation. You know, this person's chronic pain is not like that, not like that, not like that. All I'm saying is that there's no categorization that makes any sense. And the third point I want to make is that chronic pain is a phenomenon of a person. Chronic pain is something that you as a person have, and it isn't localized anywhere, in the sense that there isn't a bit of your body that is a pain meter that you can say, this is where the pain is. If I get rid of that, there'll be no pain. So taking those one at a time. And this is really partly because of the London Pain Clinic. A person with chronic pain usually believes, or starts off with the belief, some ongoing tissue damage is causing this pain. And that is hugely reinforced by the reaction of the health service, all professions on the whole, and I'm sure you probably have the same problem as rehab services have, which is everybody says, oh, we'll send you to the pain clinic and they'll deal with it. Like people used to say about rehab, you'll go down to Ridley, they'll work miracles, you'll be fine. And you get this person who's semi-conscious. And the idea of this person being fine, has been unconscious for the last 6 months, is just a joke. But nonetheless, that's the expectation set up. But chronic pain is associated with, I'm not putting cause here, just associated with affective disorders, moods, depression, anxiety, what have you, loneliness, social loneliness, isolation, lack of friends, limitation on activities, disability, drug misuse, alcohol, smoking, all sorts of things. And disease, yes, disease is one of the things it's associated with. Neurological diseases, particularly, and MSK almost certainly as well, you know, will have pain as part of that disease. But it's got a lot of associations. And I'll just remind you that associations do not prove cause and effect, but they do put that forward as a hypothesis. They tell you there's a relationship, and they tell you that it is possible that A is making B worse. So if I do something about A, maybe B will not be so bad. And if you prove that in a trial or experiment, then you have really quite strong evidence that A is a cause of B. Not the cause, but a cause. So my first belief would be that chronic pain, a patient who has chronic pain has a multifactorial etiology, for want of a better term. And there may or may not have been some original, quotes, cause, a precipitant, fell over and twisted their ankle. But that is not the current cause of their pain. I imagine that must be, nobody's disagreeing, I hope. Good. I'd be surprised if they were, but I think we all have to recognize that that is nonetheless not the position of a lot of people who are dealing with pain, let alone a lot of people who are not dealing with pain but come across people with pain. My second bugbear is about real pain, and I've taken other ones as well, but I'm sure you get the same. So I see people with chronic, you still do see people with chronic pain. And if you raise the issue about, well, maybe these things are something to do with it, many people will say, yeah, I'm sure they are. But there are people who will say, you think I'm imagining it, you just don't think it's real pain. And I've also heard therapists and doctors talk about real pain, by which they mean pain which they believe is due to some disease, with the implication, which they don't say, but if that person has real pain, you're implying that that person does not have real pain. And what do you mean by not having real pain? And they can't answer that. But so I don't think you can say this pain is real, or whatever that might mean. And equally, psychological pain, which I certainly read about, sort of has an implication, has a direct implication that it is only due to psychological causes, which I think is unlikely. And it will be interpreted by almost all members of the public and many doctors and other professions, no doubt, as being in some way of lesser importance, lesser value, not worth treating, it's nothing to do with us. It carries with it stigma. And I think we just forget how stigmatized mental illness, and I don't call this mental illness, but how stigmatized it is to get a label that is described as mental illness. Phantom pain, I always think it's a bad name. Nobody thinks phantom pain is unreal, but it's rather, the name phantom pain suggests it's unreal. I think it's strange. And I think most of what I see as neuropathic pain is not obviously due to any damage to their nervous tissue. And I suspect that there are other labels that I don't know about. And I think that this is an unreal way of trying to subdivide pain. Now, I haven't looked at the research in pain. Some years ago, I looked at the research in headache, which is a pain, and you have tension headaches, and this headache, and that headache, and whatever, and migraine. And the epidemiological evidence is the worse your headache gets, the more likely it is to be called migraine, the more likely it is you'll get all of those things, but it's just the severity. And if you've got tension headache, it's down the lower end, and then other sorts of headache, and then migraine at the other end. There is no epidemiological evidence that you can distinguish all these types of headache. And that's very important in that if you think there is a specific treatment for migraine, you may not give it to someone who you've diagnosed as tension headache, but actually all you're saying is if it's worse, we give stronger drugs. And why not just say that? So I would argue that somebody's got pain, they've got pain, and we should not try to subdivide it, partly because the label we attach will imply to some people there is some lesser value or greater value to what we're labeling it. Nobody disagrees?
Everybody seems to be enthralled.
Can I just,
Yes.
So there's a comment about something like neuropathic. That sounds like proper pain.
Yeah.
Right? This argument to
Yeah.
give people that diagnostic label, because it just sounds more.
Yeah, well, I think the problem with neuropathic pain is several-fold. I mean, drug companies have a huge vested interest in calling everything neuropathic pain because they can then recommend that you use their antidepressant, anticonvulsant, or whatever it is. So, I mean, back pain in adverts I've seen is now neuropathic pain. I don't know how it got there, but it has. But I don't think you can separate it out, but you're quite right. It sort of gives pseudo more reality. And the bigger worry to me is it drives you to give a drug for which there is very little evidence anyway, but you feel justified. Neuropathic pain, I can give this. Migraine, I can give that. We're just so hooked on words and labels that we don't think of the reality beneath it.
Certainly the harm that may be caused as a result of those labels as well,
Oh,
the
yes,
added
the harm of labels is
iatrogenic
huge.
harm.
Just related to that, Derek, just your thoughts, because I think, yeah, it feels like you're preaching to the converted in that sense, and we often have these conversations about how helpful it is to come up with all these different labels. But, you know, IASP have got now 3 categories, so nociceptive, neuropathic, and then nociplastic as this new term. I'm just wondering if you had any, I imagine your thoughts on this, but I'm wondering what your thoughts are on nociplastic.
I think my views would be that labels such as those, and there are others I'm sure about neuroplasticity and one thing or another, and pain centers in the spinal cord, I think they're fine to go and do research on it. That's fine, and you could put the names into that box. I think we need to be really careful that we don't fool ourselves into believing that there is an external reality to this that drives treatment or prognosis or some other thing in the real world. So I think if somebody has had a stroke and has burning pain down their left arm, and I don't think they've got any problem with their shoulder, I think it's a reasonable hypothesis for me to think that there's probably a large contribution from the damage in the right cerebral hemisphere somewhere. And I can reasonably think that it might, although the evidence is pretty weak, that it might be best to start with an anticonvulsant or an antidepressant. But I think it's unwise to stick the term neuropathic pain on it, because the implications of that are that other treatments which might be actually better are not tried, and that you don't think more broadly. So if somebody asks me in that situation, I would say it might be due to that. But even so, there'll be other things making it worse. And the person says, well, I don't think so. They will usually have said, when I take a history, I let the patient talk for about half an hour. I don't say anything if I can avoid it. And in that discourse that they've given me, they will often say, you know, when I'm really engrossed with the children, the pain goes away, or something like that. They will make an example of that. And I will then say to them, well, actually, you're saying to me that it's only due to that, but you've just told me that actually it goes away for half an hour when you're doing something else. Now, your brain didn't get better, the stroke didn't go away, so there are other factors coming in here. So I think it's the risk of a label is, you know, the man with a hammer goes for a nail. And if it's a nail, then you've got to hit it with a hammer. But if you haven't got a hammer, what do you do? Well, you get a stone or something and bang it in. But if you've labeled it nail, you can only hit it with a hammer. So the risk of labels is huge. And it constrains your thinking, constrains what you're doing, but it also might misguide your thinking. So I would restrict those terms to sort of experimental and theoretical discussions and be very wary about applying them to patients.
There's a comment.
Patients are messy. Everything's mixed up.
There's a comment from Fiona. She said, I think a lot of patients I've spoken to feel that they need a label to make their pain more acceptable or believable to the GP, given they've often struggled to feel heard and validated for so long before they even get to us. And I think she means probably pain specialists.
And I absolutely understand that. And that is the problem. But it's a close run thing from a patient's perspective to have a label which convinces the GP, but to avoid all the side effects of that label. So if I say you've got neuropathic pain, GP of course thinks, oh, great, now I know I go down that route.
Yeah.
And ignoring the fact that actually, you're drinking heavily, you're smoking heavily, and you live in a damp infested, rat infested place. I'd get rid of all of that. And yes, it might have a neurological basis, but that's not the issue that's going to get your pain better.
Yeah. And the other people that require labels, Rajvi points out, are the DWP.
Yes, and I think that's a huge problem. And I will, if necessary, give the DWP the label they need, but I will say to the patient, I'm doing this because it's the way around the system.
Yeah.
This is not true. I don't write that anywhere. DWP might come back and say you said it wasn't true. But if that's what they want, you have to, within not lying, you have to go on with the system. So the third point is this, that pain is in the person and not in any organ. And this is, in some ways, it's perhaps not germane, but I think it is. An example I give there, if somebody's hit their thumb with a hammer, and they will say, well, the pain isn't there, it's actually up here because I feel it in my brain. And I think the answer is, it's also you've hit your thumb. Your thumb is damaged. That's got something to do with it. The pain is something that's in the person. And there's an interesting article which is about pain, that one I've put a link to. And it's called the neurological fallacy, which applies to quite a lot of neurology anyway. And it's around some phenomena are only possible at the level of the body. And it's around attributing that phenomenon to something within the body. And there are examples, if you read philosophical literature at least, around sort of non-health related examples as well. So, in a car, and I'm making this up as I go along, but in a car, if the car, part of the car breaks down, you could say, oh, the problem is all in the wheel, but actually it might be the whole car is breaking down and the wheel is just one bit of it. It's the whole car isn't working. So it's a way of thinking about it. It's really reminding us that pain is a human experience. And in an animal, the pain is an animal experience, but it's the animal that's experiencing it, the dog or whatever it might be. So, any other comments from that? Okay.
Actually, just want to, so there's an interest, a growing awareness of the term we use, embodiment, when I'm talking about pain and the person. I'm just wondering if what I'm describing is along those lines.
Yeah, it's very much the same thing. And, if you've got my website, you can find out stuff about embodiment. There's a philosopher from Bristol whose name escapes me. It's a woman with some chronic lung disease, quite nasty. Yeah. She writes well about it. She writes well about it. And there are lots of things like that. The broader literature, humanities is something that certainly rehabilitation should study, and I imagine pain people as well. So now I'm going to talk about rehabilitation. I'm doing this really partly because I want to tell you about rehabilitation. And what I think will come out of this is an enormous similarity. So, and again, this is lifted off my website, you might say, but the primary structures, primary underlying structures of rehabilitation are two: the conceptual theoretical framework, which is the biopsychosocial model of health, and the primary active part of it, which is the people undertaking rehabilitation, which is a multi-professional. And I prefer that to multidisciplinary because there are lots of multidisciplinary services in the health service that are all doctors. They're radiologists, neurosurgeons, neurologists, oncologists doing a multidisciplinary team for cancer care or something. And then what we have to remember is that we all live within a sort of structure, which is the social structure we live in. And the culture of the people out there and the public that we're part of, it's not people out there, we're all part of it, also influences how we deliver our services, and the NHS structures, social services makes a huge, huge difference. You gave the example, DWP wanting labels, and we have to live with that. We can say to DWP, your labels are rubbish, and I have said that to them frequently. I've been on a working party about what labels they're going to do, and they tie themselves in knots. And we had a document that started off with short sentences, and then it was about 55 pages, and then it came back down to short things around disability rather than pay, but it's the same problem. So just to take those apart, again, you probably know this, but biopsychosocial model of illness was first published as an actual publication in 1977 in Science, and anyone who wants to read it, again, you can get the reference from my website, is a fascinating read because what he said is absolutely true now and nothing has changed. And he said if we don't change, nothing will get better. Nothing's got better and nothing's changed. He was quite interesting on that. Based in psychiatry, drawing on sociology and a lot of other things, general systems theory, immediately recognized by the World Health Organization as being relevant to rehabilitation and basis of the International Classification of Impairments, Disabilities and Handicaps in 1980, which you would be interested to know was somebody called Philip Wood, who was based in Manchester, who really championed this. And he didn't write the document, but he had a lot of say in it. And then the WHO took it on a bit further, the International Classification of Functioning in 2000. It's been used in rehabilitation since 1980 or before. It's been modified a bit, and anyone who wants to read about it, as I look at it anyway, can go to that paper, which has still been downloaded about, it's about 100,000 downloads over the last few years. So it's quite popular. There we are. Now this is it, and I think it's probably best to leave this with you, but just to explain what it is and a few points about it. So in the top left-hand corner, well, first of all, the red box, which goes to about halfway down, just over, is indicating the body. That is the person. That is the whole person. And inside that person, in the top left-hand corner, there's a whole lot of organs, brains, guts, whatever. And inside the organ, there will be diseases, otherwise known as pathology, and that's part of illness. And then at the level of the whole body, you have symptoms and quote signs. Symptoms are what the person experiences and reports. And it's important to recognize that symptoms and what the words we use for groups of symptoms are entirely mental constructs. So if I say somebody has, and this may not be a phenomenon you're familiar with, but visuospatial neglect. You may or may not know or remember that somebody who has a right hemisphere stroke will often have a left-sided weakness, but will at times ignore everything on their left. And we talk about neglect. And you will probably also know from common experience, people with a stroke on this side often have a problem with their language, which we call aphasia. And that sounds really aphasia, something solid. Actually, when you come down to it, there's no single item that you can say that proves it's aphasia. It's a term we use to summarize all of the things we look at. And all of the so-called impairments that we have are themselves just constructs that we put on what we observe. So I think the important thing to realize is that symptoms, whatever, are what people experience, and what they report, and then we interpret what people tell us by saying, oh yes, they're describing pain, as it would be if you're listening to a description of pain. And then the bottom bit of that red box in a sort of purpley colour or bluey colour includes quality of life on the left, and that is something that only the person themselves can decide on. It's not something you or I can decide on. The model includes what's called a personal context. Personal context is what the individual brings to the situation. So some people, having their third relapse of multiple sclerosis, they've had 2 others, they made a good recovery from both, they were 10 years apart, they're not going to be very concerned. Other people, if they had family members who died of multiple sclerosis within 10 years of onset, will have a very different view of what is happening to them. The temporal context is where that person is in their illness and where they are in their life. And these are factors that you have to think about. And then underneath is external, on the right-hand side, physical context. And that is something we can all agree on because we can see it. You and I both see there are chairs here. And so the context is the environment, and within that context, you undertake activities. They're goal-directed behaviors that will be influenced by the setting. So not here, but in some places, if I was in a wheelchair, I wouldn't be able to get here. Completely impossible because there's a step, something in the way. So activities are goal-directed behaviors that the person undertakes. And then on the left-hand side, social context is, in a sense, what it says. It's the culture and expectations of friends, and the attitudes of friends and others. And the sort of patient aspect of that is social participation, who they are in their own network. Their wife or their mother, captain of this, they take part in rugby, they teach, they play music, whatever it might be, all the things that people do. And that's what the illness is, that's what the model is about. And the biomedical model says that if you don't have something on the top left-hand side, it isn't real. So there's nothing up there. Whereas the biopsychosocial model says your activities are influenced by all of those things. And you might well present with going to the doctor, asking for help. And you might well be experiencing pain as it happens, or weakness, or whatever it might be, without anything going up on the top left-hand side. And that's predicted from this as a multifactorial model. Any questions on this?
The only thing is, Louise, it's probably reference to what you were saying a bit earlier, Derek. She said, I just think we want an explanation for why we're in so much pain. Again, it comes back to education. I was only able to begin to embrace self-management once I started to learn the basics about pain and how it works.
Yeah. So, I mean, this I think gives you a framework in which you can set it. And I use this, if I see a patient, I will run through this with them. I can describe this to a patient in about a minute and a half, and they understand it. And then I've got a framework in which I can say, thinking about you, first of all, let's think, is there any disease? And I see a lot of people with functional disorders, and I will say, no known disease will produce all of these problems. It doesn't make them any less real. They are real problems, but they're not due to multiple sclerosis, whatever it is you think you have. And I hope and think they find it helpful. So I use this model with patients primarily, and then try to explain it to doctors or others who don't understand.
Could I ask maybe a question with it, Derek? Sorry, I'm
That's
asking
right.
questions, but I guess, so this, the biopsychosocial model, whilst it's been adopted in pain services, more recently, there's growing criticism of it in terms of being reductionist and the risk of, risk of putting, siloing the different aspects of it as sometimes is how it's operationalized in services, and how they deliver it. They focus on, this part we're doing is the biomedical part, and this part is the psychological. Often the social part is neglected completely, but I guess I wondered if you had any thoughts on the kind of current contemporary kind of criticisms of it.
Well, there's a chap called, I think it's David Shakespeare, who writes quite a lot of critical stuff about it. I did actually write to him once. He wrote a very critical article. I wrote back to him saying something about it, but he never replied. So it was very difficult to know what that is. But if you go back to the article I give there, published in 2017, I go through most of the criticisms. Now, many of the criticisms are about abuse of the model. And I can't control what the DWP or other people deduce from it. I can say it's wrong, but I can't go out there and control it. I don't think the fact that some people abuse it makes it wrong or bad. And biomedical model fits within it. It's just a subsection of it. The social model, so-called, fits within it. It's just another subsection of it. I think as a framework and a model, it is comprehensive. And I can understand and have every sympathy with the misuse being bad. But it's like nuclear power, nuclear bombs, and sort of carbon-free or maybe carbon-free power. I don't think it's very good, but nonetheless, it's an example of how knowledge is there, theory is there, take it one way, take it the other. So I know the criticisms, and most of them I think are answered in the article, as I said, certainly the ones that were present at the time.
Can I think what's really nice about this is with the model is that top left side, because I think in pain, we sometimes delude ourselves. We're not talking about the top left side. So we talk about something like the neuro doctrine or the idea that explanations of pain are couched in neurophysiology. And that seems to be the most dominant view of it's what's happening with your synapses and what's happening with your, impulses. So it's still, to me, it's still in that box, which makes it really hard to see just all that other stuff.
Yeah, and I think coming back to the neurophysiological explanations and synapses, it's like depression. Depression is due to serotonin absence or whatever it is. I mean, that's complete rubbish. Depression is something in the person. They are depressed. Now, it may be that giving them an anti-serotonin uptake inhibitor or whatever might make it better, but it's not because their biochemistry is funny. And there's quite a lot of psychiatric literature about the sort of misuse and the misunderstanding of this association. The association between changes in biochemistry and mood. Okay, so what? It doesn't prove anything. So I think the problem with a lot of the pain research and pain physiology and neurophysiology is not that it's being done, because it is interesting to know, and it may lead onto a better way of dealing with it, but it probably won't. And I don't remember now exactly the details of it, and you'll know much more than me, but certainly a long time ago, central grey matter was supposed to be the place where the pain was, quotes, felt. And people went around destroying central grey matter, that pain would go. Well, it didn't go. It went for a short while, came back again. And you get people having their arm cut off because it's painful. And the pain comes back. The pain is in the person. And we may understand the physiology of how it is generated to an extent, and if that is useful in helping us manage it, so much the better.
I was wondering, Louise, you've written in the chat, Louise, did you want to just about the slide in the biosocial model, but also the kind of understanding pain and that need for a diagnosis. Did you want to say something about that, Louise?
Yeah, I think it's, again, for me, it all comes back to educating people. And I think we need to think about doing that from children, because I think most of us, until we start to learn, assume that because we're in hideous pain, there must be something awful wrong. And I think that's why people go in search of a diagnosis or a label or whatever you want to call it. And so unless that's addressed, whether it's by a diagnosis, if there is something wrong, and if there isn't, then an explanation and a good explanation of why you still hurt, but actually there's nothing wrong with you. You know, we're always going to keep on looking for that fix and for the doctor to sort it out. So for me, it does come back to education. But I agree with the slide about, you know, the multidisciplinary team, because there's so many things to take into account. One specialist, one particular type of professional can't sort it on their own, I don't think. Yeah, it's tricky, but I think that explains, for me, it's obvious. To me, it's obvious why we go in search of that label. Tell me why I'm hurting. So we assume there's a diagnosis. So when I hear professionals say, well, people just want to know, they just want a label. Well, no, what we want is an explanation. And so if it's chronic pain, then you need to explain that. And then show me where I can go to learn more about how that works. Because now I've learned, I am in a better position to self-manage my pain, and I haven't been to the doctors in I don't know how long, because I know it's within me to cope. Does that help?
It does help. And you said something which I was going to pick up on, and I've now forgotten what you said. You slipped back accidentally, as we all do, into this sort of distinction of there isn't a disease, therefore it's not serious. I think you said it is serious. It's very serious having chronic pain. And and I do it all the time. So I'm not blaming you. I'm just interested that the underlying culture of our society is such that we do it automatically.
Your slides and what Louise has said and sort of what we're talking about made me think about this idea that the absence of illness is no indication of health and wellness. That I might not have an illness, as someone described, that doesn't say how I am as a person, and the other way around. Sometimes how I am as a person might not actually indicate what is in me that could be determined as an illness. They don't. These two things are not equivocal. They're not going to match always. And sometimes we're searching for, if I'm a healthy person or if I'm a well person, I must have nothing wrong with me. And I think that's not humanity. That's not what we are as humans. We are fallible. We aren't perfect.
Yeah. Well, I think again, if you go to the website, there's quite a lot on illness, sickness, and disease and disability. And I've just bought a big philosophical book about it. And there are words that we throw around, and we need to be much more clear when we're doing it, throwing them around, what exactly we're talking about. And the problem is we're not all going to talk about the same thing. So we need to then unpick it and say what we are talking about. And I think, I'm not quite sure what you mean, but I think, or what you were saying, but I think we have to recognize that I can have a disease, and probably do, of which I have no symptoms and no knowledge. I'm 74. About 10 to 15% of people my age, if I have a CT brain scan, will have a stroke in their head, as in will have a space where I've had a cerebral infarction. I haven't had a stroke, and I'm not ill, but I've got a whole chunk of brain missing. I don't think I have, but there will be people like that.
Yeah.
So there's a disconnect all over the place. That you can have disease, and that's why people go for cancer screening. You can have a disease where you have no problems. Now, are you ill? And I think one of the people trying to sing says, you went there ill because you had a problem, you didn't know what it was, and you come out sick because you've now got a problem that somebody's recognized.
I think Fiona had her hand up, or you've taken it down, Fiona, in the audience. Did you want to ask a question or comment?
Yeah, I was just typing in the chat instead. I was just going to say that I completely agree, Louise, that you know, my statement wasn't meant to be an inflammatory, accusatory thing. It was just an observation as to the kind of conversations that I have when patients first come to our pain clinic. I was just going to say that our GP trainees have kind of latched on to coming to spend some time with our pain team. And some of the conversations that I've had with those GP trainees have been really quite revealing in how little they know about persistent pain and how scared they feel about managing it, particularly things like fibromyalgia and those sorts of conditions that perhaps haven't had such a good rap or so much understanding behind them for quite a long time. And for me, that feels really helpful. It's going to take a long time to kind of educate all the GPs to be able to manage pain well, but the conversations that I've had have been really useful, I think, in terms of helping to get people starting to think of pain as the wider picture, not just as medicine.
It's bigger than that, in that a lot of doctors and probably a lot of other healthcare professionals do not really know about the biopsychosocial model. They might say, oh, I've heard of that, but they have no real insight into what it is telling them. And certainly in Oxford, all attempts to get it onto the medical student curriculum have failed. And I did teach the postgraduate medical students, and it was very interesting to me to have a 2-hour seminar session. And these are people who went into medicine having done something else before. So they were a rather more mature group, you might imagine. And they split fairly quickly into about a third who understood perfectly well what this is about. You could see that it was true. About a third who some of them literally walked out when I was saying, you know, that it's not just disease. And about a third who sat there probably bored out of their mind, but didn't say anything. So until we get this into the world outside there, to recognize that illness is not, or sickness is not just disease, then we're on to a losing wicket. Yes, you've got a hand up.
Louise.
Sorry, just trying to unmute. Yeah, I just wanted to add that I think actually as well, when we are guided towards how we can do things for ourselves and self-manage, you know, that in itself is really empowering for people. And I think certainly for me it was, and others that I've spoken to. But it doesn't happen very quickly. And I think you need that relationship with your healthcare person, whoever that is, whatever profession that is, to sort of guide you, because I think, again, it's maybe a human failing, but if we try something and it doesn't work the first time, we tend to pack up and think, oh, well, that's it, this doesn't work. But obviously self-management is a thing that takes work, and you need to you almost need to just abandon yourself to it and make it work, I suppose. And once you do, after failing several times, you know the things that you need to do in order to stay well, and that is huge, but it doesn't happen overnight.
No, and I think one of the problems, and I can look at this in rehab, and I think it's probably the same in pain, is in a sense we shot ourselves in the foot by having, so there are level 1 rehabilitation centres, that is the top level, really difficult place. And everybody thinks the rehabilitation is very specialist, very complicated, and the John Radcliffe Hospital, an 800-bed hospital, does not have rehabilitation because they said rehabilitation has nothing to do with us. The fact that they have 20% of their patients disabled who can't get out seems to escape their notice. You know, there are 24 beds in the rehabilitation centre in Oxford, and there are 300 people in the John Radcliffe who need rehabilitation, but they can't. They've become disempowered and de-skilled. And I suspect the same has happened to pain. Pain is universal. And the idea that a GP feels frightened by treating pain, I mean, he or she is going to be doing that for the rest of their lives. They've got to get better at it. And having specialist services has a huge downside that they can only see a very small number of the proportion. And so one thing specialist services need to do is to educate not simply patients, but actually go and educate all of their colleagues who have no idea what to do, but need to know. If we're going to get to the end, I need to just move on a tiny bit. So the next structure you need is a multi-professional team, and the reason is very clear, and that's what we've been discussing. The biopsychosocial model covers a huge range of things, as you said, and no person is going to know all of those. And so you've got complex problems, and you need to cover all of that. And there's a lot of research into teams and complex problems, and sort of research basically shows that if you've got a complex problem, you need a multi-professional team. Whether you're building HS2 through the middle of London, a hospital, dealing with a rehabilitation problem, dealing with a chronic pain problem. So we need teams, multi-professional teams in rehabilitation, and you need them, almost certainly. Next. Process of rehabilitation, again, this will be very familiar to you. It's a problem-solving process. So you collect information, take a history, examine, talk to people, and whatever. You undertake formulation, which is an under-taught skill in rehabilitation. It's putting it together. Formulation is a psychiatric word, which is actually, I think, very good. It's saying these things are all making it worse, these things might make it a bit better, these things are irrelevant, this may have been the fundamental cause, and so on and so on. You just understand what's happening, including what the future is going to hold. You plan some rehabilitation, setting various goals. I really hate SMART goals, and we can talk about that or otherwise. And these goals need to be based on the patient's goals, or what their interests are, what they want. That is not to say that you have to do what the patients ask you to do. Most patients with spinal cord injury say they want to walk, and no doubt they do, and no doubt we would like that, but it's not going to happen. And you're not blunt about it, but you must face the fact and help that person to come to those terms. Then you intervene, and I split rehabilitation interventions into two theoretical components: care, which is preserving safety and well-being. So in the intensive care unit, you have care to keep you physiologically okay. In a rehab unit, it's not so much the physiological side, but it's the safety of falling or being aggressive or whatever it might be. And you have treatments, which are things that get you from position A to position B, which is better, but then you can withdraw them and the person remains there. And then you evaluate how's it gone, and then you go back around that cycle where you transfer the patient elsewhere, and elsewhere may include transferring skills to the patient who can then look after themselves. And we've been talking about this, but just to put it up, in rehabilitation, and the references there, the evidence is that we have various treatments. So exercise as a cardiorespiratory thing, getting fit, is very effective for lots and lots of things in rehabilitation. Practicing an activity, so if I need to learn to walk, I basically need to get up and practice walking. And of course, if I can't stand up, then I've got to start by practicing standing up. but once I can stand up, then I practice walking. Education is essential, including self-management skills and knowledge, but also just education about the disease and what it is and what it isn't and so on, and all the beliefs that somebody has and their family have, and you have to educate the family and often the social services carers. Psychosocial support, which is mentioned in most papers but is not well defined, but I think is to do with emotions and also trying to help the social side. And then in all rehabilitation, if you read any definitions, there's tailored individual interventions, which are a huge number of things. It might be, arranging a stair lift for somebody who can't get upstairs, who's got to go upstairs, or whatever it might be. And that is, in a sense, I'm sure, what yours would fit into that as well as anybody else. And this is the outcome, so a structured process of outcome. This is the outcome for rehabilitation. And I'll let you read that and it'll be on the slides. I mean, basically it's around being social, having a good social life, being integrated socially, dealing with pain as far as possible, discomfort, distress that they may experience, protecting the family, and often leads to debate. Do I say to this person, you can go home, knowing well that the family can't cope and won't cope or don't wish to cope? Or do I say to the patient, I'm afraid it's a care home? So there's no, that's a dilemma that you just have to face. So that's a summary of rehabilitation. And it might be best if I go on to drawing the parallels, although we've drawn many of them. Is that okay? And then we can stop and go back and discuss. So first of all, I thought about pain in rehabilitation. So I can't say from any surveys or whatever, but I would say at least half of my patients would have mentioned pain to me, or when asked would acknowledge having pain. And I've seen people with everything from sort of minor head injuries up to remaining unconscious, and MSK and amputations, whatever it might be. And sometimes it's the disease, very specifically. Often it's the bodily consequences, immobility, spasticity, it's painful, it's uncomfortable. If you don't move your joints very much, it's painful. You probably haven't noticed, but I have cut a tendon in this finger, and it's also fairly distorted. Anybody here can see, you can't see on the screen. I didn't realize how much it hurts to immobilize a joint until one day I put a plaster on it and held my finger like that overnight. I can remember the next 48 hours to this day. This was 40 years ago now. It hurt. It really hurt as that finger came back out again. So immobility is painful. Mood disturbance, which may be primary depression, but most people who are in rehabilitation have lost something, can't do something. And for many of them, depression is a perfectly natural response to what's happened. Distress, social isolation is very common in rehabilitation, loneliness, financial stresses, and so on and so on. All of these things happen, all give pain or are associated with pain. So rehabilitationists have to know about pain. There's no way that we cannot know about pain. What about pain? Well, pain exacerbates, what's it do? It exacerbates, makes things worse in motor function. If your pain is worse, you'll be less good at moving, spasticity will be worse, cognitive function, mood disturbance. Everything is worse if somebody's in pain. And certainly in rehabilitation, the drugs used are uniformly almost bad. They lead to depression, mood disturbance, apathy, sedation, fatigue, cognitive dysfunction. Tramadol is terrible at hallucinations, and so on and so on. So I would argue that pain is multifactorial, affects all domains of life, bodily functions, activity, social activity. And therefore, if you're caring for people with pain, I'm not sure whether care has a special meaning or not, but if you're just basically caring for people with pain, you have to consider all of these influences. And where you can, do something to control them. And you also have to consider the secondary consequences of those pain. And where you can, do something to improve them, which is essentially what rehabilitation is about. And in rehabilitation, if we focus on anything on activities as sort of where we put most of our effort, but that many of them have pain. And if we're going to do our rehabilitation, we have to know about pain. So I conclude that pain services should be undertaking rehabilitation using their expert skills in pain, relating to the pain, but also thinking about the wider rehabilitation. And rehabilitation specialists, the reverse, must do pain care as part of their rehabilitation. So I'd answer my question, what is it to do with pain care? A good pain care service is a rehabilitation service with a particular interest in people with chronic pain. And a good rehabilitation service is a pain service with a specialist interest in people with complex rehabilitation problems. So I would see it, going back to my original figure, which I haven't repeated, as we're all part of the same service, and we need to learn from each other and respect each other's skills, but see ourselves as collaborative, not competitive. That's the end. So I'm very happy to go back and discuss any of that.
Thank you so much, Professor Wade. Derek, thank you. I've been asking lots of questions, so I feel like I can't answer anymore. I'm wondering, I'm just looking, there's no, it's been a very interactive, it's generated lots of discussion, but we have, that's clapping hands, I think, from, do we have any questions, Leila? Are you coming on to ask a question? Yeah, hi.
I was just quite interested to see that the psychosocial support is poorly defined, because quite often we talk about psychologically informed physiotherapy or psychologically informed approaches, and that's not very well defined. There's no training route defined for it. I think that's where, in some ways, we struggle to define our identity, because a lot of us are working in services in an interdisciplinary way. Although, you know, from some of Jackie's research or other views, it might be argued that we don't need to have a psychologically informed approach to help people participate and engage in other activities that would improve their well-being. So it's not really a question, just maybe a discussion point, really. And the other thing is about social isolation, and there's quite a lot of research into how that actually adversely affects health outcomes in the long term. So, you know, for my money, I think that's where we should focus and say that's what we are doing in terms of assisting with participation.
So to pick up on the first point first, the research I did to get to that was looking at effective rehabilitation and what the people doing it said they did. And many of them said psychosocial support, but that was never clarified. And if you search on what is psychosocial support, it's really difficult to find out. I think if one thinks in reality, the danger is that we're going to think, and this happens certainly in a lot of rehab services, psychologist is needed. Off we go to another specialist. And this is sort of a minor version of this person's got pain, off we go to a specialist service. Within the service, we're saying, this person's got depression, off they go to the psychologist. I think we need to become much broader in a confidence what we can deal with. General practitioners covering all of these things all the time. And of course they go to specialists, but many of them will be covering all of these things. And many community physiotherapists are going to be giving support and all sorts of things. And we under-recognize the extreme importance of personal relationships in rehab. As a person whose name was Elizabeth Johnson, I think it was, who many years ago invented a splint for people with stroke. This would be back in the 1980s or 70s, that she put forward as being a brilliant cure for stroke and spasticity and all sorts of other things. And I went to a talk once where somebody called Gert Quackel, who is another physiotherapist in stroke, stood up and basically talked about his research and said they'd used as control because it was ineffective, the Johnson splint. She was in the audience and she was the next speaker. Sort of 4 foot nothing, nearly. I mean, she was a little bit taller. But this platform, she had to get up onto the highest table. She jumped up onto this platform and gave a talk. And the talk was such that any patient going to see her would have got better. She just had that ability, that enthusiasm. She was giving psychosocial support to her patients. I don't know about her physiotherapy, but I know that she was extremely good for the patients. So we underestimate the psychological support we give by being human and just listening and empathizing.
I think we're in a little bit of a difficult situation, because now you were mentioning about the Faculty of Pain Medicine and that 80% of it was just about interventions, basically, or techniques for pain. And they will be writing advanced practice competencies for allied health professionals. And it's likely that it's going to be a lot about biomedical types of approaches, such as prescribing or diagnoses, this kind of thing. And it's quite hard to define the power and the profound changes that can occur from what might be deemed these softer communication, therapeutic alliance type approaches that pain specialists use in terms of pain physiotherapy, I mean.
Yes, that's a problem rehabilitation faces all the time. And I think the only way around that is to just bang on and on and on about the effectiveness of what we do. We have somebody called Lynn Turner-Stokes, who is sort of living dynamo to an extent, who publishes all sorts of stuff about the cost effectiveness. Specialist rehabilitation is cost effective within 2 years. This is beginning to get through to the contracting people who are beginning to realize that it's needed. So I think there's 2 ways around it. You could try and get into the Faculty of Pain or any working parties they do and say your bit, but you'll probably get squashed. Or you can set up, this group could set up an alternative. NICE, in some of their documents, are very well aware of, they're an odd group, NICE, because half of them don't seem to be aware of biopsychosocial model at all, and half of them seem very aware of it. But you can capitalize on some of the things that they say that is sensible. And I don't know their chronic pain guideline very well, but I'm fairly certain it's pretty broad and not interventionist.
So I was part of that guideline, and it is, you're right, and as you know, at NICE you can only go with what evidence is out there, and it's always very, and Louise is on another NICE guideline around medicines. I'd like to come back to this idea of Leila's point and the psychosocial, and as somebody who's been interested in promoting psychologically informed approaches, but also then working with Jackie, my agitator disruptor. I do sometimes find myself wondering, and I'm sure, Jackie, you said this to me, so maybe it's why I wonder it. The way that we categorize it as psychosocial, when they're two huge areas in and of themselves, and it feels like by doing that, then it gives permission to just focus on the psychological or psycho, and then really kind of largely ignore a lot of the social stuff. And even Layla, again, Derek, you picked up earlier with Louise, how we sometimes even ourselves unknowingly and implicitly use language that betrays perhaps the cultural norms.
Yeah.
And Layla, you talked a little bit about, soft skills, and we do say this, and actually, there's a movement to try and switch that language to core skills. These are the core skills that we should all be developing. And so, yeah, it's not a question, it's just rambling, but this idea.
I said they were seen as soft skills.
Yeah, sorry, yes. I know you would never mean that, Layla, but it's interesting.
Well, I think we're talking about psychologically informed. I think that I can practice a psychologically informed practice because I know a bit of the psychology and I've read about it and whatever been taught about it. And, I hope that the training that goes on for most therapists, most nurses, includes stuff about psychology. So we should all be having this basic training. If you go to the medical training for rehab, you will find that these days there are 6 core skills that every doctor is supposed to have, which includes communication and knowing about ethics and all sorts of other things, which are common across all professions, if you ask me. And one of them is about communication and being culturally aware and so on. So I think it is possible to start to say there are core things we should all be good at. And basic pain control, basic rehabilitation, basic communication should be across the board.
Yeah, obviously, loving this. But I think it's the point that Layla made. It's something that came up when we were meeting with our physiotherapists yesterday, is a lot of professional uncertainty about who's driving the agenda. And, we talked about we're prescribers, but we don't prescribe because no one wants to, but we can de-prescribe. I think my thoughts around the faculty is they can write it and we can ignore it. I think there is strength in going, that's all well and good, we're not going to endorse it. And we can say to our members, that's fine, and maybe start a different conversation, because you're right, they say we're involving you, but they're not. I don't know who's being involved, someone else talking about injections and scans, and not about participation, which is a lot of our work, is helping, supporting people to get back to the social, and that's what we do, and that's not what's being discussed.
So you need to think also that what the Faculty of Health Medicine are going to recommend in their credential will apply to 0.001% of all people with chronic pain, if that. And when it comes out, or if you're in touch with somebody, a commissioner or some other group, you should say, this huge fat document with no evidence in it is applying to tiny numbers of the people. And even if it worked, it cannot be done because we just don't have that number of people to do it. And you can treat 50, 100, 200 people when they can treat one over a year. So I think you go to epidemiology, you go to, is it Ben?
Yeah. I do feel like we should caveat this with, we are starting to speak with NHS England and the faculty around how we are more involved as, all of the professions, as well as medicine, in writing, and that actually the emphasis should be with the other professions in writing credentials for the other professional groups. And yeah, you've reminded me, we need to chase that up. I think but even interestingly, given how prevalent pain is, they're not seeing it as a priority yet. They're trying to decide whether it's a priority for working on credentialing. So that's my understanding is that's where it is. But yeah, we'll be chasing this up. I feel I have to say that.
And I think also maybe just something that strikes me is perhaps we should be looking to rehabilitation to some of those competencies and do our matching and go, perhaps we're more aligned with these.
Well, I'm fairly certain that, I'm slightly certain that rehabilitation would welcome the close thing I would do, and I know a large number of my colleagues would. There are some people in the rehabilitation hierarchy who basically think it's all to do with doctors. But I think at the moment, if you were to approach and say, just want an affiliation, just a sort of close relationship, it doesn't have to be anything formal. You know, we'd just like to run a joint meeting with you one day, something like that would be welcome.
Study day.
You're involved with the Community Rehabilitation Alliance, I expect, CRA. That's certainly
Yeah, they
CFP
did
is
it
involved.
here, yeah.
That's heavily involved with, we're heavily involved with that. So there is that link there that you can build on.
I'm smiling because we have everyone witnessing the seeds being planted for some hopefully very exciting directions moving forward. I am also mindful of the time, and it's been a long day, and I don't see any further questions in the chat, and people feel that they can. But if no one else has any other questions, just again to thank you, Professor Wade, for coming along. A wonderful talk. Lovely to see how we're all aligned. Yes, thank you.